Thank you all for joining me today for this webinar. Just to let you know ahead of time, there will be an opportunity to ask questions at the end of the webinar. If you could just use the Q&A function within Zoom, and I'll address as many of your questions as there's time for at the end. So thank you again for tuning in, and thank you to the Whitaker Institute for inviting me to speak today. I'm excited to share some of our recent work on physical distancing in the context of COVID-19, to share some of what we found so far and to touch on some of what we will be doing over the coming weeks. Great. So my name is Dr. Hannah Durand. I'm a postdoctoral researcher in the School of Psychology at NUI Galway. My background is in health psychology, which is basically concerned with how biological, social, and psychological factors influence health and illness. So my PhD actually examined adherence to medication. So it's been really interesting and rewarding for me to apply the knowledge and skills I gained in my PhD to the topic of physical distancing. Now, before I get into the talk proper, I would just like to acknowledge my assistant Rufus here. He's a bit vocal on the issue of physical distancing, so if he barks out of turn over the next hour, please excuse him. He's just very passionate about this topic. But in all seriousness, I would like to acknowledge and thank the project team that I work with. So Dr. Jerry Malloy is the primary investigator on this project. And the collaborators and staff on the project are Molly Byrne, Jenny McSharry, Laura O'Connor, Una Mead, Brian McGuire, Chris Noon, Kim Lavoie, and Simon Bacon from the Montreal Behavioural Medicine Centre, Aina Kenny, Karen Farrell, and Robert Mooney and Kate O'Flaherty from the Department of Health. So I'm really fortunate to get to work with this group of experts. We've got world-leading expertise in behavioural science in this group, but also having collaborators from the Department of Health, including members of the National Public Health Emergency Team Behavioural Change Subgroup, which is now the COVID-19 Communications and Behavioural Advisory Group, has been a really crucial element of this project in terms of shaping the project to make sure the work is useful and relevant, but also that there's a clear pathway for our findings to be fed back to policy and decision makers. So I'd just like to acknowledge that before we begin. So I would usually start off a talk like this by defining whatever topic or behaviour or condition we're going to be talking about. But I'm not going to describe for you what COVID-19 is. You know, we're all living with it, and I know so many people are really just sick of hearing about it, myself included. So we all know that COVID-19 is a highly infectious disease caused by a novel coronavirus that to date has been mitigated through the use of primarily behaviour-based prevention measures. And one of the most powerful of these is physical distancing or social distancing. I prefer the term physical distancing, so that's the term I'm going to try to use going forward, but if I kind of swap them around, please excuse me. Now, physical distancing is another term that we're all really familiar with at this stage. You know, it's something we've been asked to do for a year now. We just kind of see it as part of our daily lives at this point. So now when we do have occasion to leave our households, we know that we need to practice physical distancing. But seriously, like what does physical distancing actually mean? Well, when we asked people what they understood by the term physical distancing, they described basically this: keeping 2 meters of physical space between them and other people. And while this is a correct answer, it's not really complete, because physical distancing is actually a whole set of measures designed to, yes, keep physical distance between people, but also reduce the number of times people come into close contact with others, with the aim of preventing the spread of contagious disease. So physical distancing covers not just taking a step back from people, but also things like school and workplace closures, avoiding crowds and crowded places, stay-at-home orders, cancelling mass gatherings, travel restrictions, quarantine. All of this kind of falls under the umbrella of social distancing measures. So instantly, it's a lot more to think about than a simple kind of 2 meters of space. So you'll recognize these kind of yellow bubbles from all of the government communications, and instantly we can see it's not just one simple distancing kind of cue or behavior, it's a whole host of other factors that we need to consider in order to keep ourselves and other people safe. Now, I don't know about you, but I had certainly never heard of physical distancing prior to this pandemic, but of course, physical distancing is nothing new. Leper colonies were an example of a physical distancing measure dating back as far as the 14th century. And of course, there have been several notable examples of physical distancing measures in much more recent history. So for example, during the polio epidemic in New York City in 1916, for example, that looked an awful lot like what we're being asked to do now. So recreational facilities were closed, public gatherings were not allowed, things like that. Very similar kind of measures put in place to curb the spread of that particular disease. In more recent years, school closures have been a really important measure to stop the spread of certain infectious diseases, notably SARS and swine flu. And of course, the current restrictions are probably the most extreme example that we've seen in our lifetimes thus far. And of course, there's a good reason why physical distancing measures are used. Simply put, they work and they work quite well. It's probably the most effective tool we have to mitigate the impact of infectious diseases that are not yet well understood and don't have effective treatments. So this is just a simple simulation comparing the spread of coronavirus infection where people do not distance on the left versus do distance on the right. And you can see very quickly everyone on the left becomes infected, hospital capacity is exceeded, and people die, versus on the right, where each dot is in contact with far fewer dots, the disease cannot spread as far and is much more contained. So this is, familiar to a lot of you, I'm sure, what we were talking about much earlier in the pandemic, probably during lockdown 1, but admittedly, time has kind of lost all meaning for me. But we were talking a lot about trying to flatten the curve, reducing community transmission and keeping hospitals below capacity. And we've seen that physical distancing measures are key to achieving this. But we know physical distancing is important and it works, but why is it so bloody difficult for us to do? It seems to be a much more challenging behaviour for people to adopt relative to other prevention measures. For example, in the very early stages of the pandemic, a poll by Amoric Research found that only about half of respondents reported sitting further apart from others, versus 90% of people who said they were washing their hands more often. So it certainly appeared even then that physical distancing was a more difficult behaviour to initiate and perhaps to maintain as well. And there are multiple possible variables that are likely to account, at least in part, for the resistance to physical distancing related behaviour change. People need to have awareness of what the behaviour is that they're being asked to do. They need to have the ability to carry it out, but they also need to have some belief that measures are personally relevant and important, and have the social and environmental resources required to adopt that behaviour. And these factors, particularly people's beliefs about COVID and the importance of physical distancing, are likely to vary according to kind of key demographics and membership of certain at-risk groups. So for example, people who are in the older age groups or who are immunocompromised are likely to have different beliefs about the importance of physical distancing relative to people who are at much lower risk. We also have different needs across the course of the lifespan. So for young people, for example, that need to socialize, that kind of drive to connect with others is far more important than, say, for somebody in midlife, for example, whose needs and sort of developmental stage is very different. So trying to get young people to adhere to physical distancing that kind of prevents them from socializing with friends and peers in that really important developmental way is going to be a bit more difficult. Additionally, adhering to certain physical distancing measures requires us to break lifelong habits. So if you think about somebody who's struggling with loneliness, for example, somebody who's feeling isolated, the natural thing for that person to do is to seek out connection with others. And typically, that involves coming into close contact with another person. We would instinctively want to hug a friend or hold their hand, things that pre-pandemic we would have done without a second thought. So as well as conscious reflective processes, beliefs and things we have to think about, to adhere to physical distancing, we almost have to override instincts that are hardwired in our brains. So things that we've done automatically until now, we're now expected to change. So, again, a behavior that sounds quite simple on its face quickly becomes much more complicated. So with all of these kind of theoretical explanations for adherence to physical distancing in mind, we wanted to identify what are the actual determinants of physical distancing adherence in Ireland in the context of COVID-19, and figure out how best to use targeted messaging to address some of those determinants. And to do this, we designed 3 studies or work packages. In the first, we carried out a cross-sectional observational survey study in collaboration with the International COVID-19 Awareness and Responses Evaluation Survey, or the iCARE survey. In the second, we interviewed members of the public via phone about their experiences of physical distancing. And in the third, which is just about to begin really, we aim to conduct a content analysis of current government messaging around physical distancing to see do current messages optimally target key determinants of adherence. For anyone who would like a bit more information about the methods of any of these studies, a protocol for this project has been published. It's available fully open access through HRB Open Research, and it's indexed as part of the coronavirus collection there. So first I'd like to talk to you about the iCARE study. When we were planning out this project, one of our major concerns was, every day, almost every hour at that stage, people were being inundated with survey after survey, asking roughly the same kind of questions about the same kind of things. And we were concerned about the burden that people were being placed under with regard to requests to take part in research at what was, an incredibly scary and stressful time. And we were also concerned about research waste. So, with that in mind, rather than inventing our own survey, we were fortunate enough to have the opportunity to collaborate with Kim Lavoie and Simon Bacon, directors of the Montreal Behavioural Medicine Centre and co-leads of the iCARE study. Now, the iCARE study is a Canadian-led, ongoing, multi-wave international study involving the collaboration of more than 150 international researchers from 40 countries, including Ireland. And the overall aim of this study is to assess public awareness, attitudes, concerns, and behavioural responses to the COVID-19 public health policies on people around the world. So for the purposes of our project, with funding from the HRB and the IRC, we used a MORAC research panel provision services to target a large nationally representative sample of Irish respondents. And this just meant that our sample was representative of the national population in terms of age, sex, geography, and socioeconomic status, which means we're better able to generalize to the population as a whole. So our nationally representative sample looked like this. We had 1,000 participants ranging in age from 18 to 89 years with a mean age of 45. About 22% were over the age of 60 and therefore considered to be at high risk from COVID-19, according to the HSE. And about 37% had at least one pre-existing health condition that also meant they were at high or very high risk from COVID-19. So in terms of adherence to physical distancing measures, so again, we're talking about a suite of different measures you'll see listed along the bottom of the screen there. But adherence was pretty high to most measures here. So the lowest rates of adherence were for avoiding social gatherings, but just to kind of contextualize that, this data was collected in June of 2020. And at that time, we were in phase 2 of the government's short-term emergency response plan. So small social gatherings were allowed at that time of up to 6 people indoors or outdoors. So that may explain there's, maybe a bit of confusion around that particular item because social gatherings were allowed and the survey didn't differentiate between small and large gatherings. But overall, I think this data paints quite an encouraging picture about the level of adherence that we were seeing in the Irish population at the time. Excuse me, that was awareness to government restrictions, apologies. Awareness of the restrictions that were in place at the time versus adherence. This is the adherence data, apologies for that. So, adherence was generally quite high. Again, highest adherence for maintaining a 2-meter distance, avoiding non-essential travel and avoiding bars and restaurants, which were also open at the time. So we, again, just a little bit of context, we see quite a hefty proportion of people saying not applicable here, particularly for the self-isolating items. Now, based on the high levels of awareness at the time, we kind of infer from this that people are saying not applicable because they either hadn't traveled or were not a suspected or a confirmed case. But just to bear that in mind when interpreting this data. But overall, I think this paints a really encouraging picture of the level of adherence that we were seeing at the time. In terms of kind of determinants from a socio-demographic sort of group perspective, there were some age differences in adherence. So people aged between 25 and 34 years were the least adherence to a number of different measures, specifically maintaining the 2-meter distance, avoiding social gatherings, and avoiding non-essential travel. But the differences were quite small. There wasn't a major gap in adherence based on age there. Participants aged between 18 and 24 were the most adherent to self-isolation measures. So about half were reporting self-isolating after return from travel versus about a third for other age groups. And just over half reported self-isolating if they were a suspected or confirmed case, relative to just under half for all other age groups. So again, small differences, nothing too alarming there, but interesting to look at that. In terms of gender, women were marginally more adherent to physical distancing than were men. So slightly more women, avoided non-essential travel, were able to work from home, and consequently were more likely to avoid public transport at the time as well. And slightly more women than men also reported avoiding bars and restaurants. But again, small differences, nothing too striking to report there. In terms of socioeconomic status, there were some interesting differences here. Participants from the higher socioeconomic group reported avoiding social gatherings slightly less frequently than those from the lower group. And people from the higher SES group reported avoiding non-essential travel more frequently than those from the lower group. As expected, people from the higher SES group were more frequently able to work from home and consequently avoided public transport more frequently as well. In terms of risk category, participants with a chronic physical health condition that placed them in the high or very high risk category reported avoiding social gatherings, avoiding non-essential travel, and avoiding bars and restaurants more frequently than those in lower risk categories. And with regard to mental health and quality of life, there was actually no difference in frequency of adherence to physical distancing between people with or without a depressive disorder and with or without an anxiety disorder. But people who reported that their quality of life had become much worse as a result of the pandemic reported slightly poorer adherence to all measures than those whose quality of life had remained the same or changed for the better. And the difference there was on average about 8%. So reasonably large there, impact of change in quality of life in the pandemic. Unsurprisingly, those who considered the government measures to slow the spread of COVID-19 to be very important reported the highest levels of adherence to almost all measures. And those who found the measures to be too strict reported the lowest adherence among most physical distancing behaviours. But encouragingly, the vast majority of people felt that the measures were important and that they were about right in terms of stringency. And actually a sizable proportion of people, about 11%, I think, felt that the measures were actually too lenient and they wanted to see more restrictions put in place at that time. Now, with regard to different policies and strategies that governments use to promote adherence to physical distancing, participants reported that information about how their actions were helping to slow the spread of COVID in the community and how they were helping to save lives was most likely to persuade people to adhere to measures. Now, information about how COVID-19 is spread, about COVID-19 related complications and risk of death, and limited healthcare resources were also rated as highly motivating. But information about international infection rates, death rates, impact of our actions on the economy, and threats of fines, arrest, and quarantine were rated as less persuasive than more kind of positively framed strategies. Now, apologies, I know that was a bit of a data dump, but I'd like to focus a little bit on my kind of personal take-home messages from that study. I think it's important to acknowledge that this data is a snapshot of a period in time when restrictions were more lenient than they are now. And a lot has obviously changed since then, but I think it's still a really important snapshot all the same. What was really striking for me is that, the Irish people in generally have done really well with physical distancing. People are highly adherent to this measure. I think considering the extent to which we've been asked to change the way we live our lives in this totally unprecedented circumstance, the vast majority of people have made a Trojan effort to do that, to protect themselves and to protect each other. And I think, that needs to be acknowledged, and we deserve a pat on the back for that. I've taken this quote from a poem that's been circulating about the pandemic. It says, we're in the same storm, but we're not in the same boat. And I think that's really apt for this project in particular, where we are seeing certain differences in socio-demographic groups in adherence. But, as I've mentioned, for the most part, these differences are quite small. There isn't really one group that's sticking out for me as being particularly non-adherent to these guidelines. And where there are gaps in adherence, I think it's more likely that there are unmet needs there rather than an apathy or a deliberate violation of the rules. So messaging that specifically targets groups who are maybe not as adherent as other groups may be warranted. But more than that, I think addressing underlying social inequalities that may have contributed to these results and that will have been exacerbated by the pandemic is needed. I think our energies will be best spent trying to address these factors that undoubtedly affect a person's ability to adhere to physical distancing, than trying to place blame on any particular group, which I know has been, an issue in the media of late. And relatedly, this data says to me quite clearly that positively framed messaging is the way to go when it comes to promotion of COVID-19 mitigation measures, as opposed to kind of punitive fines and arrests and kind of threatening approaches to try and get people to comply. I think that's a really important kind of take home from this. Now, of course, there are limitations to this study. We didn't have the resources to repeat the nationally representative sampling for subsequent iCARE surveys. So this data does represent a cross-section of behaviours that are rapidly changing. And also using the iCARE survey as opposed to creating our own survey locally didn't allow for deviations from the international study protocol in response to the specific trajectory of the pandemic in Ireland. So for example, there was kind of a shift in phases around the time that we were collecting the data, and we weren't really able to account for that in terms of trying to sample from phase 2 and phase 3, for example. It also meant that we couldn't be as specific about certain terminology as we might have liked, particularly around self-isolating and similar concepts that appear to be used a little differently between countries. So when you would self-isolate and do you self-isolate or do you quarantine, or the terminology there, we weren't able to be as specific as we may have needed to be. But of course, we had to weigh those limitations against the risk of participant burden in a very busy research space, and the potential for research waste as well. But it does mean that our next work package, I think, is even more important. So that is our qualitative exploration of barriers and facilitators of adherence to physical distancing. Just before I get into that, I'd like to acknowledge my brilliant colleague, Karen Farrell, who's led this particular work package to date. So the aim of this study was to explore in greater depth the barriers and facilitators of adherence identified in the quantitative analysis in work package 1, and to provide more in-depth insight into the role of Irish context-specific determinants of behaviour that were beyond the scope of iCARE. And this was one of the first qualitative studies of adherence to physical distancing measures during the pandemic, which is a really important study to contribute to the literature, to provide insight into people's feelings, opinions, experiences, and so on. So we carried out 25 one-to-one interviews via phone, which were audio recorded and transcribed for analysis using Brown and Clark's thematic analysis. Now, before I go into the results, I'd just like to acknowledge our public and patient involvement group pictured here. They're such a really lovely group to get to work with, and they've made such an important impact on this work package in particular, from helping us figure out who to recruit, how to recruit them, what questions we should ask, And now they're in the middle of helping us kind of wrap up the qualitative analysis as well. And you know, I think because we as researchers are also living through the pandemic and experiencing it, I think it's really more important than ever to engage with members of the public on COVID research. So we really do try to reflect the diversity of experience in Irish society. And our group has really helped us to do that. And from a practical perspective as well, you know, the group provided really nice solutions to different issues that I don't think the researchers really would have come up with. And that has had a really tangible effect to date. So in particular, we were able to recruit a large sample of participants for interview really quickly in a very busy research space, as I've mentioned. And I think that's, you know, that's no doubt down to their advice. I'd like to acknowledge them here at this point. Now, in terms of the sample we recruited, participants ranged in age from 18 to 80 years. Slightly more than half were female, and they represent a kind of diversity of occupations and kind of socio-demographic backgrounds, which was really important. You know, we wanted this study to be as representative of the Irish population as possible so that we could kind of get maximum variation and represent a diversity of views. In terms of the analysis, so that's resulted in the kind of construction of 7 major themes that I'll go through in turn. I just have one illustrative quote for each, just in the interest of time. But you know, we hope to be able to share the results of this study in full with you all soon. The first theme is habituation to risk. So participants kind of described how the anxiety and the worry of the virus had diminished for them over time. So particularly for those who maybe didn't have direct experience of COVID-19, so who hadn't become infected themselves, who didn't have a close friend or family member who had become ill with COVID-19, there was a level of complacency and almost disengagement from, you know, the physical distancing messaging and from that restriction. So, you know, this participant said, oh, at the beginning, it was more like, stay the F away from me, please. It was very, very odd. But now I've kind of relaxed a bit more because I'm just emotionally worn down. And that was common throughout the interviews. The next theme was maintaining and negotiating close relationships. So many participants described the difficulty of not being able to see or having to keep that 2-meter distance from family members and close friends outside of their household, and how abnormal that all felt. You know, not being able to, you know, hug somebody or, you know, pat them on the shoulder and things like that. You know, they really struggled with that, and it just felt strange. For example, this participant who said, you know, the hardest part I find is with the family or with my own sisters. There's 5 of us and we used to meet every few weeks in each other's houses, and like, that's gone. Each of us find that so hard. I mean, talking on the phone to somebody is not the same. In addition, you know, people described the worry and anxiety of having to negotiate distancing with their friends. And, you know, some people reported feeling like nervous to ask people to keep 2 meters from them, even friends, not just strangers, you know, when they were meeting up for social gatherings, you know, for fear that there might be kind of feelings of awkwardness or embarrassment, or that friends might not place the same importance on distancing as that individual did themselves. And they're kind of concerned about their ability to negotiate that relationship while also adhering to the rules. The next theme was loss of social interaction. So younger people in particular talked a lot about missing out on social aspects of work and education and this kind of move to working remotely. So the hustle and bustle of college life and, you know, all these normal everyday interactions that we maybe would have taken for granted before, you know, how much they really missed that. So just for example, this participant said, it's just kind of reduced my contact with people in general, whereas I would have usually possibly seen like dozens of people a day, and actually had interactions with dozens of people a day through work or just through socializing. And that's basically just been reduced down to myself. I think it's reduced your level of comfort with your colleagues and things like that. It should be said though, on the flip side of this, you know, some people found the move to remote work and remote learning really helpful. So they found it a bit easier to manage, not having to get to know like the physical layout of a new university kind of made managing postgraduate education a bit easier to deal with, for example. The next theme was safety in retail and recreational settings. So there was kind of a mixed bag here between, people feeling kind of comfortable or uncomfortable in different kinds of retail or recreational settings, particularly around food. So like supermarkets, bars and restaurants. So there were mixed opinions on the safety measures taken in these settings, very different experiences on the physical layout of different venues that they had visited, where people felt that, there were positive and negative aspects to kind of, going to the shop or going out for dinner. So for example, this participant said, I did leave a shop kind of in the end of spring in my hometown. There were no controls in place. I'd gone in with my sister and people weren't wearing masks. I think there was actually somebody coughing in the shop. I remember having this kind of, feeling of, oh God, I've never felt so uncomfortable in my local shop. And like we went into the shop and I think within 2 minutes I said, right, we're just leaving right now. I'm not staying here. It was just there. It was no physical distancing. People were standing upright beside you and just super, super uncomfortable. And the next theme was being in control of the controllables. And that's a direct quote from a participant that kind of summed up that talk about personal responsibility and behaviour. So many participants felt that they were the main person responsible for their own adherence or non-adherence to the public health advice, that it was their personal choice to physically distance from others, not just to protect themselves, but protect their family members, friends, and people around them. So there was a sense that, that personal responsibility narrative was important to a lot of these participants. Versus, say, placing the responsibility for maintaining adherence to physical distancing on the government or on, people who run different kinds of businesses and venues and things like that. So this participant said, I'm very much in control of the controllables, and it's probably a way of controlling the situation for me, has been taking precautions that I believe are best. In terms of using sanitizer, wearing my mask and keeping distance, and being really conscious of not mixing with big groups of people or lots of small groups of people within a short space of time. I suppose that's reduced the worry for me because I actually don't know what else I can be doing. So that sense of control is really important, that feeling that, there was something they could do to kind of take back a little bit of control of their lives. They had the ability to prevent themselves or their family members from becoming sick by adhering to the rules. The next theme was confusion and uncertainty around government guidelines. So we have the 5 levels, and then there's the rules on the household, how many houses can visit and how many people. I mean, I have no idea. I have no idea. We're at level 3 now, and I don't know how many households and how many people. I think that kind of made it a bit difficult. I think that kind of confuses things an awful lot for things like socially distancing. I think that really kind of sums it up, that particular participant quote. People felt that the guidance on household visits in particular was quite confusing because it had changed quite a lot in a short space of time around the time these interviews were conducted, so between September and October. This was also at a time when different counties were in different levels, so there was confusion around that, and sort of unclear guidance around physical distancing in certain settings, and not always being able to kind of maintain a gold standard of 2 meters. And the final theme then was risk compensation to maintain well-being. So this was an interesting one. There were certain activities or hobbies that people kind of felt it was worth taking a bit more of a risk in terms of, not adhering to the public health advice for the kind of benefits to their well-being and to their mental health. So, things that really brought them a lot of joy, that kind of social connection, for example, and a sense of kind of release from the pressures of the pandemic and all of the restrictions. So they might choose to take greater risks in a certain setting to allow them to engage in a behavior that was, more important to them. So for example, this participant had identified one area of my life that I kind of give myself a bit of an extra lead, being able to, I suppose, interact a bit more, I suppose, put myself in scenarios where distancing might not be as possible as other areas, but the payoff of it mentally for me is huge. So that was a really important kind of almost like a balancing act between trying to adhere to the rules, but also look after your own kind of well-being and, you know, mental health as well. And how do we kind of navigate those choices that we have to make? In terms of conclusions, I think, you know, this study kind of in a lot of ways reflects the findings of work package 1. You know, there are a number of, you know, internal and external psychosocial factors that determine whether or not someone is going to be able to adhere to physical distancing in particular settings or at particular stages of their lifespan, or, you know, given certain kind of occupational settings and things like that. And I think the diversity in our sample is really important here, because, you know, it shows how much these barriers and facilitators can change depending on your context. So again, it does appear that kind of targeted messaging addressing different subgroups of the population, you know, it's important, but I think they may need to consider psychosocial kind of variables in a more concrete and nuanced way to really get at the things that are important for people and the motivators of adherence for the general population as well. Now the final work package is a content analysis of government communications around physical distancing. Now, as I've mentioned, we haven't really started into the analysis piece here yet. So I will just quickly mention it before wrapping up. And I welcome any comments or suggestions on this piece also. You know, it's a nice opportunity to make a comment before we actually start into the work on this. So our plan is to content analyze posters intended for distribution via social media, news outlets, print media, signs on public streets, and so on. You know, those yellow posters that we're all very familiar with now. So specifically, our plan is to kind of break these messages down into categories based on who they're targeting, you know, the length, the number of words, and so on. But also to code the content of these posters for established behavior change techniques using the behavior change technique taxonomy. And then these techniques will be mapped onto one of the 26 mechanisms of action using the theory and techniques tool. So, excuse me. So a report of these findings, you know, identifying any gaps there may be in current communications and making recommendations to support development of tailored messaging, you know, addressing these evidence-based determinants of adherence, using established behavior change techniques, you know, techniques that we know work to help people to modify their behaviors, will be provided to the Department of Health and to the National Public Health Emergency Team via our connections with the COVID-19 Communications and Behavioral Advisory Group to help inform future messaging. So to conclude, it's kind of a rapid whistle-stop tour of this whole project. And, you know, not to repeat myself, but I do keep coming back to this quote in my own head that, you know, I think it's really vital that we as researchers, as policymakers, you know, government officials, the media and the general public, I think we need to take a step back and make sure that we're taking a compassionate approach to promoting adherence to public health guidelines, and that we more actively work to reduce inequalities in our society that make it really difficult for people to adhere to the guidance. You know, we know already that there's unequal access to remote work across income levels. We know that fining people for not adhering to restrictions disproportionately impacts those who are least able to pay. You know, there are important policy level interventions to be made here to try and address that. You know, we need proper social welfare for people who are unable to work during the pandemic. You know, we need sick pay for people. We need to address like unequal distribution of work and childcare in the home. You know, and we need proper accessible mental health supports to see people through this storm as well, to make sure that people have the necessary resources to really engage with the messaging, with the restrictions, and to adhere. So I think, you know, it's kind of beyond time now to bin the blame game and the judgment and take a much more compassionate approach to trying to promote these behaviours we need to see to kind of get us through the pandemic until a time when, you know, we do have, you know, mass vaccination and herd immunity. Physical distancing isn't going anywhere. We're going to have to adhere to these kinds of restrictions for many months to come. And I think, you know, we need to really take a much more compassionate and generous approach to the people around us, and appreciate the challenges that we're all facing, but that, you know, you don't necessarily know about another person. So just to wrap up, I'd like to acknowledge that this research was funded by the Health Research Board and the Irish Research Council. The iCARE study has funding from several different sources, which are available on the NBMC website. I'd like to thank the staff and students at the NBMC who have been really supportive to us in carrying out the iCARE study in Ireland. And again, you know, massive thank you to our public and patient involvement group for their invaluable input into the project to date. And, you know, looking forward to getting their input on work package 3 as well. So thanks everyone for your attention. My contact information is on the screen. So if you do have any questions, I will attempt to answer them now, but equally, if you'd like to follow up with me after the webinar, that would be very welcome. So thank you. Yeah. I don't see any questions in the Q&A box, but if you do have any questions, please feel free to ask them that way. I'll read out any questions that come in and then provide my answer so everyone can hear, because I don't know if you can see the questions that other people have asked. So I've just seen a question come in. The chat function is disabled. So if you have any questions or comments, if you can put them into the Q&A box as opposed to the chat box. Okay, so I have a question from Brian McGuire. Hi, Brian. So any thoughts on distancing in schools? Yes, I think, you know, schools are obviously a very challenging setting to try and facilitate distancing. You know, I think trying to get very young children to, you know, curb that instinct that they have to you know, hug their friends and get up close and you know, look in each other's books and things like that is going to be really challenging. You know, they have that kind of impulsivity of youth, and trying to get young kids to adhere is going to be really challenging. Even, you know, the physical space doesn't really lend itself to distancing in a lot of cases as well. You know, certainly if I think to my own primary school, which is still operating and doing the very best that they can to support distancing within the school, you know, you've got those 2-person desks, the classrooms are quite small, it's hard to configure that. So I think that's, you know, it's important to be aware of. I think, you know, trying to protect our teachers in schools as well. So trying to facilitate distancing for them, because, you know, as adults, they probably are more at risk of, you know, serious complications from COVID-19. And, you know, we're asking a lot of our teachers to go into those, you know, potentially quite dangerous settings, because you don't know what a child is kind of bringing from home as well. You know, I think prioritizing teachers for vaccination would be an important, you know, step to try and address the potential risks in school settings. because, you know, I just don't see that there's an easy answer to distancing. You know, it's I think a lot easier said than done to try and facilitate appropriate distancing in school settings, particularly for younger children. I hope that kind of answers your question. I don't have a good answer for that question, unfortunately, but I think it is about trying to mitigate risks in other ways where distancing maybe isn't possible. So I have another question from Laura O'Connor. Hi, Laura. So Laura asks, have participants in the qualitative study talked about things that encourage them to physically distance if the more negative messaging discourages them? Is it about the practical supports such as sick pay, work from home policies, or perhaps more about stressing how much of a difference physical distancing makes? That's a great question. I think, you know, people did talk a lot about what helps them to adhere. So in public spaces, for example, there was kind of praise for, you know, those like stickers on the floor to let you know how far you should be away from somebody in a queue, for example. Those sort of physical environment things that not only like make it impossible not to distance, but kind of cue you to remember, like, okay, I need to make sure I'm keeping space from people. Things like screens, one-way systems, that sort of stuff was all kind of, you know, talked about very positively. You know, back then when bars and restaurants were open, you know, when tables were appropriately spaced, you know, they talked about like, oh, the tables might be 2 meters apart, but the chairs are not. So that was, you know, something that if you actually kept the chairs 2 meters apart was rated as something that, you know, was really helpful. You didn't have to think about it so much if the physical environment sort of facilitated distancing for you. And that was something that people really liked, you know, not having to be so conscious of it all of the time, because, you know, the physical environment helps you to do it without thinking. There was also a lot of talk about work from home and how it just naturally makes it easier because you're not having to come in contact with so many people. There wasn't really much talk about sick pay, but, you know, I think there was certainly around the time maybe kind of media discussion about people who kind of couldn't afford to not go into work if they had come into contact with somebody. Maybe they were symptomless and they were going to take that risk because they had no options. So I think, you know, sick pay is going to play an important role going forward. You know, I think even once this pandemic is blissfully over, I think this is going to have to change the way we engage around, you know, social welfare, sick pay in general. You know, we can't have people kind of going into work if they have the flu or they have some other kind of contagious disease. So, you know, that those supports are going to have to be implemented at some point, you know, if we don't want to end up in difficult situations like this in the future. And as well, you know, not so much in the qualitative, certainly it was apparent in the iCARE data, stressing how much of a difference physical distancing makes does seem to work. So that kind of positive framing that, you know, what you're doing is helping, you know, that we are flattening the curve, or that, you know, we are reducing the R number, providing kind of, you know, concrete examples of that was really helpful. One person mentioned the, I don't know if you remember this kind of graphic of a couple socializing over a weekend, and, you know, how that led to however many cases over those couple of days. That kind of thing was rated as really helpful. So like a really concrete example of how not distancing can result in a lot of infection, but, you know, distancing can prevent that. So that kind of thing was really helpful. It was really tangible for people, particularly when a lot of people don't have personal experience of COVID-19. So hopefully that answers your question, Laura. Thank you. And we have another one here from Victoria. Hello. So Victoria asks, can you please clarify on work package 1 regarding the composition of the study population? Specifically, does this phase of the study include persons with disabilities and or persons living in residential care settings? So that is a good question. I would actually need to go back and look at some of the demographic information to see, do we have that? Those weren't factors that were kind of specifically targeted. We were really looking at, age, geographical kind of distribution, socioeconomic status, and gender as kind of our nationally representative variables. So that was kind of what we were predominantly targeting. So I would need to kind of go back and look and see, do we have that information? But I think largely, it's unlikely we have, a lot of people who are in residential care, for example, or people with disabilities, just based on kind of the model that Amoric research uses to recruit their nationally representative samples. So, that is, of course, going to be a limitation, because those are, important groups that may not be as well able to adhere to physical distancing as others. So that's an important kind of aspect of the sample that we would need to report. And finally, I think we have one more question from Sinead. And Sinead asks, do you think that the cohort of people less likely to be physical distancing are less likely to take part in the study, or is that a problem for the study in any way? That's a good question. Again, I think that's where the NatRep sampling was important for the iCARE study. So people were incentivized to take part. They sign up to an Amoric panel, for example, and they're sent surveys to take part in. So it meant that, we weren't trying to do like just convenience sampling. And, when you kind of do that, you obviously have an overrepresentation of people who, feel strongly about the topic that you're doing research on. Similarly, for the qualitative study, there was an incentive to take part. So participants received a €25 one for all voucher for their participation. So we would hope that, incentivizing might mitigate some of that, that we wouldn't just get people who are, highly adherent and want to talk about how adherent they are. That is an important consideration. It's even with medication adherence, you have the same thing, like that non-adherent people don't typically take part. But we would hope that the strategies we've used to recruit for these particular work packages would mitigate some of that. But it is, of course, it's always an important consideration with this kind of research. So thank you. I don't have any more questions in the Q&A. Thanks everyone for engaging with that. Some really good questions, really useful for me even to think about when writing up the results of these studies, which we're kind of working on at the moment. So thank you very much. Thanks again for listening and for engaging. And again, if anyone would like to follow up on anything, please do contact me. We'd be very happy to chat about anything. But otherwise, thanks and goodbye.